Okay, thank you very much. I'm here speaking on behalf of an entire group of investigators that put together a fantastic multi-center trial coming from an original experience, which was the DoReMi trial, which was basically oriented to understand whether or not we are delivering adequate dose to patients. And our main results in the previous trial that was published a few years ago, there was one important observation. Patients were receiving less than 20% less than what was prescribed in terms of dose. The median delivered was 27 milliliters per kilogram per hour compared to a median prescribed of 34. So this was enough to consider the possibility that part of the mortality in the ICU patients could have been related to the fact that a certain amount of patients certainly deliver suboptimal treatment dose. There was clearly discussion on the different papers published on the so-called dose-dependent region and practice-dependent region, and what is the breaking point, which has been today identified between 20 and 25 milliliters per kilogram per hour. Nevertheless, this is effective delivery. And we know that especially in non very well experienced centers, you have probably to overprescribe in order to get this amount of dose. Now, there are other reasons why patients tend to die, and one of these reasons is fluid overload. So the literature is full of studies showing that patients tend to have a worse outcome when they are fluid overloaded. And we know from a slide that has been presented yesterday that actually in the ICU we have the so-called magic window, which is the right optimal fluid status, which is not too much dehydration, not too liberal intake or positive balance. Especially if you have a diseased heart, this window of opportunity for optimal fluid status gets narrow and narrow. So based on this concept, we wanted to make a new study in which practically we wanted to investigate the impact of daily fluid balance in real life and fluid accumulation on mortality of critically ill patients from the moment they are admitted to the ICU. Our aims were to evaluate the incidence of AKI and AKI requiring renal replacement therapy, the cumulative fluid balance after admission. So somehow we are not responsible for what happened before, but certainly we want to know what happened once the patient reached our ICUs, evaluate the influence of fluid overload on clinical outcomes, and also in presence or not of AKI. So the endpoints were to development of AKI requiring renal replacement therapy, and what is also renal replacement therapy in practice in the field, and what is the ICU mortality. Basically, we had patients from 21 intensive care units from 9 different countries, and we collected baseline data, and then after that we computed the fluid overload every day based on the percent weight variation from admission to the present point of calculation, and we also calculated mean fluid overload and also the slope of fluid overload over time. So this is the main picture. You see that over the 1,700 and more ICU admissions studied, 743 patients developed AKI, and out of these patients, of course, we have patients that have AKI at admission or developed AKI after admission. And here you see the different percent of patients that require or did not require renal replacement therapy. Of course, we have some small number of patients that require renal replacement therapy, even in the absence of AKI. In most of the cases, it was the problem of fluid overload that was taken care by extracorporeal therapies. The first vascular access was in most cases femoral or intrajugular, minimal and marginal percent on subclavian, and the modality of renal replacement therapy actually was in a vast majority continuous renal replacement therapy, although in some patients intermittent therapy was also applied. There were some unplanned interruption of treatment in quite a large number of sessions that were studied, and in most cases, this was due to filter clotting or premature dysfunction of the filter. The type of anticoagulation that has been used was known, heparin or citrate, and as you can see here, we mostly use citrate in CVVHD according to the protocol utilized. In terms of filter survival, you see here the number of filters and here the time of filter survival. I would like to point out that patients who received heparin as a standard therapy, they had a filter survival in the range of 24.24 hours, and in several centers, the filter exchange at 24 hours was the practice. So practically this was somehow underestimated. This, of course, citrate was providing longer survival in case it was used. And here you see. But the interesting thing is that we are now analyzing at 24 hours, and we are seeing that not necessarily this is statistically significant. So the possibility, in case of change of filters at 24 hours, that it makes no difference. Now, the surprisingly good answer from this study was that the dose effectively delivered was always above the recommended standard. In some cases, it was well above. In fact, in CVVHDF, the effective delivery dose was about 40 milliliters per kilogram per hour, which is surprisingly high. But the interesting thing is that in most cases, the median delta between effective delivery and prescription was practically very marginal. Of course, with the little wider variation in case of convective therapies. Now, coming to the fluid balance from admission, you may see we have divided patients into groups, no AKI, AKI, and AKI requiring renal replacement therapy. In all these groups, there is a progressive slow fluid accumulation over time. And here you see what is the peak fluid overload per group at different time points. So patients of no KI peaked at 2 at the second day, and 2.8% fluid overload, AKI at day 3, and AKI requiring renal replacement therapy at day 5 with a peak fluid overload of 7.9. Now, the interesting thing is that these patients who were treated with renal replacement therapy started to decrease and go back to almost normal fluid status by day 9. In every point at the moment of peaking fluid overload, you see the difference between survivors and non-survivors. So non-survivors always had a higher fluid overload compared to survivors. Now, when you analyze patients who developed AKI, at least in those in which you can have the data prior to that, at least 3 days, because of course some patients developed AKI just on admission, you may see that there is a progressive fluid overload before and after the development of AKI. And here you see practically an interesting survival estimate in which you clearly see that patients that actually require renal replacement therapy have the worst outcome compared to patients with AKI not requiring renal replacement therapy and patients with no AKI. Now, in all patients and in the different groups that were studied, non-AKI, AKI, or AKI requiring renal replacement therapy, you see that the level of fluid overload in non-survivor was always higher. And here you see the fluid overload trend to discharge or death. In survivors, there is a progressive negative fluid balance, while in non-survival, there is a progressive increase in fluid overload. And now when you look for unadjusted models or adjusted models where you have Apache or AKI as risk factors, the fluid overload still represent one of the risk factors. Now, the new result of this investigation is that we always in the past discussed about 5% threshold, 10% threshold, 15% threshold, especially in the paper published by Stu Goldstein in children. Now, what we have seen is that this increased mortality actually starts at the very, very beginning, and even 1% fluid overload is significantly different from no fluid overload in patients. And of course, there is a composite result when you have higher Apache 2 scores. The difference between AKI and non-AKI group is a completely different story. Now, another thing which we analyzed is the slope of fluid accumulation. And we calculated this from the baseline point to the point of maximal or peak fluid overload. Now, what you see here, for example, is two examples in which 1 unit of the fluid overload slope, which may resolve into 700 milliliter fluid intake daily, increase the hazard of death by 1.32. So we are in a condition now to know that it's not just how much fluid overload is present, but also how fast you accumulate fluid. And again, this is the unadjusted and adjusted model, and you see how the fluid overload slope play an important role in the hazard ratio for mortality. So what are the key points? What did we learn from this study? CRRT is probably the most used modality provided to patients with AKI. Femoral access is quite frequent. The use of citrate seems to increase, allowing longer filter and circuit patency, but in most cases, heparin allows for uninterrupted 24-hour treatments. Different modalities are utilized with preference of CVVHDF. CRRT still suffers from unintentional interruption and significant downtimes, but most treatments are adequate and in some cases even at higher doses than recommendation. Discrepancy between delivery and prescription was lower than previously observed. So people are doing CRRT much better compared to what they were doing 10 years ago. And a change in ICU patient care has probably occurred regarding fluid management because what we saw is that there is a less severe fluid overload compared to study made 5 or 10 years ago. Still, however, the amount of fluid overload being low, it was correlated with mortality, and actually, it was higher in patients with AKI, and especially in those patients requiring renal replacement therapy. Remember, we need to arrive to day 9 before we correct the fluid overload, which peaks at day 5 in patients that require renal replacement therapy. So the speed of accumulation is important, and in different models, considering all possible other factors, the magnitude and the impact of fluid overload on survival is confirmed. This is one of the largest prospective data collection in real world. Fluid overload observed in all groups is quite low compared to previous studies, showing that a careful administration policy has been implemented in most units. In spite only few patients exceeded a fluid overload of 10%, most of them did not reach the threshold of 5%. Mortality was still dependent on fluid overload in a continuum function. Our study documents that daily fluid balance tends to be positive in the majority of patients from the day of admission until discharge. At similar value of fluid overload and maximum fluid overload, patients overhydrated at admission may probably do worse, and the new findings of the study are mainly the increased change to die for any level of fluid overload and the augmented hazard of death related to the rapidity of fluid accumulation. With this, I would like to acknowledge all the authors, including Engineer Garzotto, Marlis Osterman, and all the friends that have participated, and especially Daniele Marcelli, who helped us very much in the statistical evaluation of data. I have to tell you that probably today or Monday, this paper will appear in Critical Care and it will be available online. Thank you very much.